Hello and welcome everyone to the part 2 of the December journal summary. The first study is glutamine relieves hypermetabolic response in burn patients. In this study, they included around 69 patients out of the eligible 80, and they included 28 in the analysis in the intervention group and 27 in the placebo group. And in this, they found that the inflammatory marker is less in compared to placebo when treated with glutamine. So glutamine helps in reducing the stress response. So the next study, again a COVID-19 study on infliximab or namilumab versus placebo. In this, they screened 300 patients, 146 were enrolled in namilumab 52, in usual care 45, and in infliximab 28. And in this, they found that the use of namilumab resulted in better outcomes compared to the usual care group. Next study is a effect of non-invasive ventilation in COVID-19 in almost 137 hospitals. Here they screened 4,754 patients and they included 1,491 patients. And in this, they found that the use of non-invasive ventilation was associated with worse outcomes compared to high-flow nasal oxygen. The next is a open-label trial, that is the ESCAPE trial of personalized immunotherapy in critical ill COVID-19 patients. Till now, the immunotherapy that we have been using are the steroids and tocilizumab. Here they added something extra, that is anakinra, based on the inflammatory markers and the immune response. And in this, they found that use of anakinra was associated with better reduction in the inflammatory markers and better outcomes. So anakinra could be an alternative to tocilizumab in COVID-19 patients. The next is a thing that always intrigues us, that is the diagnosing capillary leak in critically ill patients. This was an innovative scoring method which they used for non-invasive detection. And in this, using the various parameters that have been shown over here, they tried to score how to predict capillary leak in critically ill patients. And in this, the particular method was very effective in finding out how to detect capillary leak. Another important trial, that is the radar truth trial. This is the feasibility of conservative fluid administration and resuscitation compared to usual care in critically ill patients. This was the strategy with which they were used. That is, basically they tried to keep the patient negative once they get a cumulative balance of more than 2 liters or edema at two sites. Then, if there were no contraindications, that is vasopressors mostly, they gave diuretics and they targeted a negative balance. So, this is what they basically tried to do. They screened 1,000 patients but included only 200. Ultimately, 100 each in each group were analyzed. Here we can see that the primary outcome, that is the fluid balance and all, was very, very significant, and the cumulative fluid balance on day 3 and 5 were all better in the intervention group where they were actively looking to de-resuscitate the patient. This is a graphical representation of the fluid balance on each day, and the most important, that is the cumulative fluid balance, as we can see over here, is drastically getting reduced by day 5, which could have a positive impact on patient outcomes. One more study on non-invasive and invasive ventilatory strategy in hypoxemic respiratory failure. This is basically a network meta-analysis, and the thing that they found out in this meta-analysis was CPAP was a very good method to give in acute hypoxemic respiratory failure. However, if the patient requires pressor support, it is associated with excessive tidal volume and lung injury. So whenever you are giving a pressor support along with the CPAP in patients with acute hypoxemic respiratory failure, be very, very cautious and always keep in mind that excessive tidal volume can cause lung injury. This again is a predictive score for 90-day survival in patients with COVID-19. Here they had a lot of parameters ranging from day 1 to day 14, from lactate to respiratory SOFA, renal SOFA to day of extubation, VAPs, the use of neuromuscular blocking agents and everything. Based on this parameter, they try to predict what would be the outcome of 90 days. And in the end, they found out there was a very good predictive value of this course in predicting 19-day mortality with COVID-19. One more study on convalescent plasma with COVID-19, which showed no benefit. The next is again a very, very important study. We had two trials this month. The next is again on the high flow nasal oxygen in severe hypoxemia vis-a-vis NIV. Here we can see that even if we looked at patients who were exclusively treated on HFNO or NIV, the mortality is slightly higher in HFNO. However, the transition when the transition occurs from HFNO to invasive mechanical ventilation, the mortality rate in NIV is much higher, which means that if the patient is maintaining on HFNO, then it is all good and okay. But if the patient is not maintaining on HFNO, trying to use NIV as a better tool for managing this patient is not going to be effective. Rather, it's going to be counter effective, as almost a lot of study have shown, especially this month. The meta-analysis showed that a positive pressure, that is a pressure support if given in the NIV, is going to hamper the tidal volume and cause lung injury, which probably was the reason why we had a higher mortality rates in patients who transitioned to into invasive mechanical ventilation. So as of now, the data summarizes that if manage the patient on HFNO, if the patient is not maintaining an HFNO, instead of going to NIV, it is always better to go for an invasive mechanical ventilation. The next is Lyndsey Lumab, that this is a GM-CSF antagonist in COVID-19, and in this they found better outcomes with Lyndsey Lumab, almost 2 times better outcome, and the outcome improved once they added remdesivir and steroid to the group, becoming more statistically significant. Molnupiravir, oral treatment for COVID-19 non-hospitalized patients. In this study, which they screened almost 1,600 patients and randomized 1,430 patients, and they found that Molnupiravir reduced the hospitalization rates and death rates, especially if the patients were unvaccinated. More importantly, it had better effect in reducing hospitalization rather than on mortality. So the next and the final study is a meta-analysis on the hydrocortisone, ascorbic acid, and the thiamine regimen, that is the HAT regimen. This meta-analysis showed that there is an improvement in SOFA score on the first 72 hours. The most important is the reduction in the vasopressor dosage in patients with sepsis. However, if we try to translate it into a mortality benefit because of the slim improvement in the SOFA scoring, because there is a specific and only improvement in the cardiac score, that is the vasopressor reduction, which may not be reflected in the overall mortality. But then the drug that we are giving is mainly to reduce the duration of vasopressors. So I think that should be the primary outcome we should be looking rather than mortality. So based on this study, we can say that the use of HAT therapy for septic shock especially can be done as of now, even though there have been a lot of studies published till now with no mortality benefits. Thank you for your patience and check our website for further information.